Let's talk about renal physiology. So kidneys are really important. You knew that already. So first of all, to think about the fact that there's a difference between sort of renal issues, which are more physiologic, and urologic issues, which are more anatomic. So basically, when you're talking about renal, we're talking about nephrology. And a nephrologist is related to this thing, the glomerulus, the functional elements of the kidney. The urologist is more interested in the collecting system, which I have a slide in a minute that'll talk about that. So what do the kidneys do? They filter out waste products. They cause acid-base buffers to be secreted. They regulate electrolytes so that your potassium's not too high or too low. They secrete renin, which is essential to the renin-angiotensin system, which is critical to blood pressure. So they secrete erythropoietin, which is the stimulus to the bone marrow to produce and release red blood cells. And they also activate vitamin D. Vitamin D exists in the system, but it really has to be activated before the cells can use it. And we'll talk about that. So this slide is probably just an extra, but just to remind you that there's a reason that certain elements bind with other elements, and so if you've got something that's a 1+, it's probably going to match with a 1-. So sodium chloride. If you've got something that is a 1+, a 2+, it's either going to match with a 2- or it's going to match with 2 molecules of a 1-. So just to remind you how chemistry works. Just also to remind us that the sodium in the cell is actually very low, with the potassium in the cell being very high, and the sodium outside the cell is pretty high, with the potassium being low. This is especially important because if there is lysis of cells, that potassium will come out. It will give you an artificially high potassium. So the first time or any time you see a high potassium, your first thought should be hemolysis or lab error, basically. This occurs because of the sodium-potassium pump. If the sodium-potassium pump isn't working, then obviously these numbers change. But just to remind you how sodium and potassium work. So the kidney has a cortex and it has a medulla. Each of those do slightly different things. Again, the collecting system is urology. The parenchyma. Parenchyma is a word that means functional tissue rather than structural tissue. That's the nephrons. That is nephrology. So here we are. We can look at the collecting system here. We can see that the urine is formed in the nephrons. It travels down here into the pelvis of the kidney. It collects in the pelvis of the kidney, and then it goes down the ureter. This is the UP or ureteropelvic joint. The UP joint is right there. Or I should say junction, not joint. The UP junction, and if you have a stone at the UP junction, it's up pretty high and it's got a long way to go. If you've got something at the UV junction, that's at the ureterovesicular junction, and that's way down at the bladder. So going back to the nephron is also basically the functional portion of the nephron is the glomerulus, that cluster of blood cells and blood vessels. It filters out the bad stuff, and then it goes into the tubules. Like 125 milliliters an hour is filtered out of the glomerulus, and then it's reabsorbed usually, or the majority of it is reabsorbed selectively through these tubules. There's a proximal, then it goes down to the loop, then it comes up to the distal, and then it goes into the collecting tubule, and I have a diagram for that right here. And you can see that different things do different functions. You can see sugars and amino acids are actually reabsorbed here. This is where the SGLT2 medicines work. They basically turn off that reabsorption and allow the sugar to go down and be excreted. Sodium and potassium are regulated pretty much here in this in the ascending limb of the loop of Henle, and as well as up here. So there's varying places where there's absorption, reabsorption. Parathyroid hormone is secreted in response to calcium or phosphate changes, and it regulates the amount of those things in the blood. Vasopressin is also secreted based on osmolarity. So osmolarity is the density or the thickness of the blood. And if the blood becomes too thick, then we'll try to retain some more fluid and dilute it. And if it's too dilute, we'll try to get rid of some more fluids. Again, so osmosis, most of the passive is water and urea. Active transport occurs for sodium, potassium, chloride, calcium, and magnesium. And again, 125 goes into the filtrate. Most of that's reabsorbed, and the normal GFR is probably somewhere between 60 and 125. Some people consider it to be higher than that, but as long as it's at least 60, you're going to be pretty functional. So glomerular filtration rate and creatinine clearance, we tend to use the numbers interchangeably clinically. They are subtly different things physiologically. For our purposes, we can consider them to be synonymous, but they're not exactly the same thing. So to look at renal function, we look at creatinine, that's the waste products. We also look at BUN. BUN is protein that's been broken down. The thing about that is that there's varying other things that can affect it. If you're very dehydrated, your BUN will go up, even though your creatinine will actually be pretty normal. And so we look at that BUN creatinine ratio. The normal should be 1 to 12, 1 to 15. If it's higher, it tends to indicate dehydration. Creatinine clearance is actually the number that we look at to see whether the kidneys are really functioning well or not. And we can compute that using a formula. The formula that's used in the laboratory assessment doesn't include weight, doesn't include various other things, and that's called the MDRD equation. It was from a dietary study, and they tried to figure out using laboratory testing how to figure out creatinine clearance. The problem with that is that it is not considering age, it doesn't consider weight, it doesn't consider gender, and so this calculation is considered to be more accurate. And so you can easily find it on your Hippocrates calculator or MD Calc, or any of those will actually give you all of these calculators. You can do a 24-hour urine. Very difficult to do, take a lot of time. Lots of times you're 2/3 of the way there and somebody will throw out a urine specimen and you have to start it over. So sometimes we do it, but more often than not, we're going to calculate it. And again, we talked about the ratio, and that's a sign of dehydration usually. What can we do? Well, we'll often look at this BUN creatinine ratio. Crit will usually go up before sodium will. Normal ratio between hemoglobin and hematocrit is 1 to 3. And so we look at these lab tests. Pulse will usually go up if somebody's dehydrated, well before the blood pressure will go down. Usually specific gravity will also go up. Tissue turgor is kind of an unreliable sign. You can factor it in, and especially if you can't get laboratory testing. But tissue turgor is notoriously problematic in the elderly because they don't have a lot of elastin. So uric acid is another thing that is excreted in the urine. It is made predominantly because someone has taken in purines. If those things build up, it can cause gout. It is a bit tricky to interpret because the problem with gout is those crystals have sequestered in the joints. When they sequester, the uric acid can actually go down because all of the uric acid has gone into the joints, but it will compete with aspirin and other similar structured chemicals, period. So other urologic issues, kidney stones, we'll talk about those in a little bit. Just to remind you, there is a test called Litholink that's a 24-hour urine that tries to see what types of substances are in the urine and would be most likely to form stones. We're not really going to talk about prostate issues today just because we'll cover that when we talk about genital urinary issues. UTIs we'll talk about, and we'll have a slide on urinary incontinence. Why do some people get lots of UTIs? Women get UTIs more than men because of their short urethras. Sexual activity will cause trauma to the area and sort of push the bacteria up. If someone is dehydrated and doesn't flush out the urine, lots of different factors. Some people will have low IgA levels or decreased mucin production, and it does put those people at risk. If someone has a lot of recurrence, it's worth considering that. What else can cause cystitis? So what's cystitis? Well, cyst is the prefix for bladder. Cystitis is inflammation of the bladder. Most cystitis is infectious, but not all. You can actually have a sterile cystitis that occurs due to a chronic inflammatory process of the bladder. Sometimes we have to even put things like DMSO inside the bladder, although we're not doing that much anymore. Pyelonephritis is, by definition, inflammation of that collecting system of the kidney. So neph means inflammation of the kidney. Pyelo means that it's traveled up through the tracts. If it actually has come in through the bloodstream and inflamed the glomeruli, that's glomerulonephritis. So they are substantially different. Urethritis is inflammation of the urethra, often occurs with cystitis, very common in certain sexually transmitted infections such as chlamydia or gonorrhea, but there are some other issues that can inflame the urethra. Just even bubble baths in little girls or even little boys can cause inflammation. So Mrs. Breene. Mrs. Breene is a 70-year-old woman. She's got dysuria and frequency. She has urinalysis, which shows yellow urine, no glucose, bile or ketone. Specific gravity is 1010. The normal is 1003 to 1030. She's got 2+ blood. She's got a little bit high pH, trace protein, urobilinogen's a little bit high. She dips positive for leukocytes and nitrites. And on the microscopic, you can see 20 to 30 red cells, 20 to 30 white cells, a few squamous cells, a few white blood cell casts. Vitals are actually pretty normal with a little bit of a high blood pressure and a very minimal elevation of her her temperature. She's got 98% O2 sat, and she's got 3 out of 10 pain. So we'll talk about the physiology and pathophysiology here. So again, temperature goes up with any sort of inflammatory process in the body. Blood pressure could be from the pain. Hard to assess that, but you need multiple readings before you can make a diagnosis of hypertension, and other vital signs look fine. So pain and inflammation. Inflammation causes increased pain chemicals to be released. The inflammation usually, decreases the lubrication and protection. You can get a bacterial infection, you can get atypical bacteria, and you can also get viral. Viral is not very common in the urinary tract, but is very possible. Yellow urine, clear, no glucose, no bile, no ketones. This does not, of course, rule out diabetes. Average threshold's about 300. So you're going to have a pretty high blood sugar before you spill into the urine. Specific gravity is 10-10. If it's higher, they're more likely to get a UTI. Probably not particularly related to sexually transmitted infections. Urine pH, hers is 8. This is the normal range. Therefore, hers is a high normal alkaline. Why is she alkaline? Well, she might be losing some hydrogen ions due to diarrhea or something like that. It's also something that happens when you have certain types of bacterial infections, such as Proteus and Pseudomonas. So it does make it a bit more likely that if she has an infection, it's something like Proteus or Pseudomonas. What can you do? Sometimes trying to change the urine pH will decrease kidney stones. And there's certain types that are associated with each one. This is where the litholink comes in. There are certain medications, antibiotics, that work best in the presence of either an alkaline or an acidic environment, just because most antibiotics actually are filtered out of the kidney and then travel down through the tract and exert its influence there. Some say that things like vitamin C will make the urine more acid because it's an acid. Interestingly, salicylates and citrus fruits actually seem to make the urine more alkaline, which is very counterintuitive for people. Proteins and carbs actually make the urine more acidic. It is hard to find a definitive source that tells you exactly what each food is going to do. It's very probable that it may even vary a little bit from person to person. So hematuria, blood in the urine, 2+, usually that's on a scale of 1 to 4. If it's painful, that would be normal with a urinary tract infection or a kidney stone. Painless hematuria is a lot more concerning because it's a bit more likely to be associated with a cancer. And again, in her case, she's got the urinary frequency, the dysuria, and so she's probably either got a UTI, maybe a stone, but with all those, the nitrites and that other kind of stuff, it's more likely to be an infection. So, we're looking for these various types of stones. We had mentioned those already. Why do stones form? Probably because of concentrated urine. It's calcified and increases the probability. There's some theory that there's a matrix that forms from certain reasons. There's certain inhibitors that if they're not working right, the patient will be more likely to develop stones. The symptoms of a stone are usually based on where it is in the ureter. High in the ureter, it causes back pain. Mid-ureter, it usually causes back pain and nausea. And then the low ureter, it can sometimes cause testicular pain, nausea, and back pain. Some references say that most stones are apparent on X-ray. The problem is that even if 10% aren't, you really need to know whether it's causing any sort of backup in the ureter, hydroureter. And so the other thing is that it's very difficult sometimes on a bladder X-ray, a KUB, which is the same thing as a flat plate of the abdomen, to decide whether something's a phlebolith or a stone, because phleboliths are actually just calcifications within your blood vessels. And again, you really want to know if somebody has hydronephrosis. If you've got it just unilaterally, you can probably tolerate it pretty well. Obviously, if both are blocked, that's a much bigger deal. Stones treatment, we try to let them pass on their own. If they won't pass on their own, sometimes we basket them and pull them out if they're way down low. Other times they have to be broken up with ESWL, extracorporeal shockwave lithotripsy, and then the patient will usually pass them. Hopefully they don't then block a ureter and have to have other problems. In the old days, we used to remove them surgically. That rarely is done today, fortunately, because it's usually a long hospitalization and very painful. The biggest prevention is usually hydration. There's some evidence that would seem to suggest that lemon juice decreases the risk of a number of different types of stones. So protein. Her protein is trace. The concern of that is that she's got some damage to her kidneys, because if you have damage to your kidneys from diabetes or from hypertension, you can actually start spilling a little bit of protein. It's also possible that it's related to her infection, may even be artifactual on the dip, just because there's other things in the urine. So it can be a mild transitory. We know that a lot of kids will have it transiently and that it'll just go away. Problems with the dip, but we are concerned that there is albumin in the urine. Now, the primary way we test this with diabetics is we do a microalbumin creatinine ratio. And it will actually test to see whether or not the albumin is a lot higher than it should be based on the amount of creatinine. The level of concentration is obviously going to make a difference there. So we definitely should pay attention in diabetics, but also probably even in hypertensives. We don't usually test hypertensives as often for this. Nephrotic syndrome is a condition which happens where the kidney just for whatever reason starts peeing out protein. There's damage to that basement membrane. Some kids get it from an IgA deficiency. There's a number of different things that can do it, but sometimes these folks will lose a lot of protein because they don't have any protein to hold their fluid in the vascular spaces. They'll get substantial edema. It may just be idiopathic, but it could be related to diabetes, lupus, an infection. And also, weirdly, they lose some of their anticoagulation substances, so they actually might be hypercoagulable. So it definitely has to be paid attention to. Strangely, we often use a lot of the same drugs that we use for immunosuppression for kidney transplants and that kind of thing. Urobilinogen, hers is 2, the normal is less than 1. Conjugated bilirubin is the liver conjugates the bilirubin, and if it's not working at all, it won't conjugate it. If it's blocked at all, it can't get it out through the bile, and sometimes it builds up in the urine. So it's possible that she has some sort of other process going on. I would probably just repeat this after her infection is treated. It can happen with hepatitis, cirrhosis. Pyridium can also do it, and that's always something you want to find out, is whether somebody has used azo or pyridium, just because, one, it'll change the color of the urine and you can't dip it accurately, and two, even though this is an over-the-counter medicine, it can cause hemolytic anemia or methemoglobinemia. Methemoglobin is a different type of hemoglobin that really is not very effective in binding oxygen. Normally we have, 1% or less in our bloodstream, but again, azo can cause that to go higher. So that's why it has a warning on it, never use it for more than 2 days. So she shows 2+ leukocytes, her nitrites are positive. Now the urine normally has nitrates in it. It should not have any nitrites. If it has nitrites, that means there's some kind of a bacteria in the urine that are converting nitrates to nitrites. Many gram-negative bacteria will do this. The gram-positives don't do it as much. And gram-positives are much less likely, but do occur as a cause of urinary tract infections. Her microscopic shows 20 to 30 red cells. Anytime you got more white cells than red cells, you're thinking infection. Squamous cells are usually skin cells. Some people feel like that's just a contamination, no sense of even bothering to culture it. The evidence is conflicting on that. White blood cell casts. Casts are a sign of inflammation and damage of the kidney itself. So even though this is really probably a bladder infection, the fact that there's some casts mean that we have to pay attention to it and make sure that it's not ascending into the kidney. And again, this is actually a study that was done back in 1998 that basically said that, squamous cells have a predictive value of bacterial contamination of about 21%. Not always. Doesn't mean that you can't culture something if it has squamous epithelial cells. Usually they're identified as epis or epithelial cells. Renal cells are also technically epithelial cells, but they are identified usually as renal cells, and those really should be 0 to 1. Anything more than that, you worry about damage to the kidney. So we think she's probably got an infection, maybe still a little bit of a chance of a stone, but I think it's unlikely. The nitrite is not pathognomonic of infection, but it's damn close to it. Pathognomonic is a word that means you can make the diagnosis on the basis of that one finding. Renal function, there's nothing here that flags us. We would need to do blood tests to know more. Hypertension issues, yes, her hypertension is up. Is she having some damage to her kidneys? Probably not, but we will need to maintain and watch it. If it's a kidney damage thing, it could even be a secondary hypertension, but I don't think we really have any evidence of that at this point. Could think about doing a CMP or a liver profile to see whether or not her direct and indirect bilirubin are elevated in the bloodstream. Indirect is often elevated in Gilbert syndrome and may be a normal variant, but if direct is elevated, that would be concerning. Should you think about STDs in a 70-year-old woman? Increasingly, we are seeing that. You may want to get a little bit more history if there's anything that tips you off and makes you think that that's a possibility. Urinary incontinence. So the most common type of urinary incontinence is actually urge incontinence. That's probably related to either a mini stroke or a stroke or some sort of inflammation of the bladder. Urinary tract infections will cause an urge incontinence. Stress incontinence is also, many people think that's the most common. It is very common, but urge is actually technically, statistically slightly more common. Stress, we used to think that was mostly related to having babies. We now know that since a lot of nuns do get stress incontinence, it's probably actually related to the weight that's associated with having had babies, as opposed to the actual structural issues there. Functional incontinence is actually just not being able to get to the bathroom on time. Overflow incontinence is when you have a full bladder and you can't empty it and you just overflow. That's usually related to a man that has a prostate problem. Reflex incontinence would be something that a spinal cord injury would get, and total incontinence is self-explanatory. Kidney issues, again, remember that many nephrology practices have hypertension in their name, so that is the specialty that you send people to that have problems with hypertension. Erythropoietin is produced in the kidneys, so if you have somebody with kidney failure, they'll often have a low hematocrit and hemoglobin. You go into a dialysis unit, many of these people are diabetic, many of them are hypertensive, a bunch have polycystic kidney disease, and there'll be a few that took too many NSAIDs. I actually wonder, with a great cutback on narcotics that we're trying to do if we're going to see more people with renal failure associated with NSAIDs, but I have not actually seen any data so far. This is actually renal artery stenosis. Renal artery stenosis usually causes increased blood pressure. You have to be very careful because in people with ACE inhibitors, they normally get their feedback from a normal kidney. And if you give them to someone that has a renal artery stenosis, they'll often get a very high potassium, and their creatinine and BUN will go up too. So chronic kidney disease is classified into 5 stages. Generally, we only see the stages diagnosed from 3 and on, just because 1 and 2 are so mild that really you have to either find some polycystic kidney disease or some proteinuria to diagnose them. Glomerulonephritis, again, is usually caused by a strep infection. Other infections can also do it. They'll spill huge amounts of protein, just like someone with a nephrotic syndrome. They might also have an ANCA vasculitis or an IgA deficiency. Certain medicines, although we don't use hydralazine very often, we do use allopurinol quite often. Haynock-Schoenlein purpura and systemic lupus are also possible causes, so just do a thorough differential if you have somebody that you think has glomerulonephritis. Vitamin D is a fascinating thing. I have backed off a little bit from doing quite so much testing and supplementation, just because the evidence that I've seen really suggests that the benefit of supplementing is actually modest, if at all. It's also strange because there is some feeling that by giving people high doses of vitamin D, we're actually decreasing their parathormone levels, which is changing the way that their bones are functioning, and that we probably should be way more careful with vitamin D supplements than we are. Vitamin D2 comes from plants, D3 from animals. The general feeling is D3 is probably preferred, although it's really sort of, the evidence is sort of circumstantial as opposed to hard evidence. When you get D3 in your system, it has to go through the liver and it's converted to a 25 hydroxynated version. And that occurs because of a cytochrome P450 enzyme, the 2R1. It then goes to the kidney, and it's actually converted into its completely active form, which is the 1,25 hydroxygenated D3. And again, the problem is that if you don't hydroxygenate it into that version, in the kidney, you'll have normal levels in your body, but you won't be able to use any of it. This is why nephrologists are always testing this 1,25 version. When we test it, we tend to just test the 25OH, but the nephrologists, as they say, tend to do the other. If you give too much, you can actually cause kidney failure. You may cause thinning bones. There is concern about excess vitamin D, although not to everybody. Vitamin D is essential for calcium absorption. With somebody with osteopenia or osteoporosis, the general feeling is that calcium supplements are not useful. Calcium in the diet is pretty important, but vitamin D will help them absorb that. And the other thing is that giving too much vitamin D, as we mentioned, may suppress parathormone. So let's talk about kidney cancer just briefly. I haven't talked a lot about cancer, but I just wanted to make sure people are familiar with the TNM system, which is the tumor, node, and metastasis system. My experience has been that if kidney cancer has more than 2 centimeters, the prognosis is worse, although the staging actually defines it by 4 centimeters. So the T portion, TX is you can't figure it out, you don't know, you don't have the information. T0 is no evidence of a tumor. And then T1 is less than 7 centimeters. T1A is less than 4, T2 is greater than 7, so you can see that that is a way to classify it. T3 extends into the veins, etc. Now the nodes, if you can't figure it out, it's an NX. If you're quite sure there's no nodes, all of them are negative, it's an N0. And then if there is nodes, it's an N1. And then if there's no Mets, it's an M0. Distant Mets is an M1. And MX is usually used if you don't know yet or can't figure out whether there's any metastasis. Now this is one of the things that a lot of people talk about is they'll talk about stage 4 cancer. Most cancers are staged as either 1, 2, 3, or 4. And this is the kind of chart that you really need to be able to stage a cancer. So if you have a very large tumor, a T4 tumor with any positive nodes and no metastasis, that's actually stage 4. Or you could even have a T1 tumor with positive nodes and positive metastasis, that is stage 4. So you need these charts, you need to be able to figure out to actually stage a cancer. So that summarizes what we're going to talk about for today. I'll put some discussion questions up on the discussion board and we can chat. Bye.